So let's get started with the webinar today. A little bit in terms of, go back one slide here if you would, Michael. We're covering the new COPs. Like I mentioned, this is not comprehensive. Every slide won't be covered. The key areas are in red. Those are the key areas you need to, we'll be focusing on, that you need to be able to identify. And like we mentioned, we're partnering, DeVero partners very well with a number of third-party consultants and other solutions, and we're very proud to have Healthcare Synergy as a longtime partner. We're very excited to have them here. The spirit of these webinars is to get information out to the industry that's valuable, that will make a difference for you, and is at no charge. So we're so happy to have so many folks on the line here. Healthcare Synergy you may be aware of. If you're not, I'd encourage you to look into them. They offer some great services, coding services, PPS billing services, consulting, OASIS review, and they have a new comprehensive chart review service so you can be survey ready every day. It's a new and innovative program that they've put out there. And Michael Tidd will be presenting today. Also on the line, we have Kat Zinsman from DeVero. And Kat, would you mind telling a little bit about what DeVero does?
Sure, gladly, Rob. So again, thanks everyone for taking the time today. Don't want to spend too much time, but for those of you who don't know who DeVero is, a quick rundown for you. DeVero offers a cloud-based EMR solution that's adaptable, user-friendly, and can really support multi-service lines on a single platform. Our goal as a company is to build a product that helps to future-proof agencies and organizations in the landscape of a transformation in healthcare. Our flexibility lends itself to responding to regulatory changes, including the conditions of participation that we're going to be covering today. The focus of the presentation will be absolutely to share detail and provide an overview of the conditions of participation changes we are all eagerly anticipating that come into effect in July. And this is for the general audience for home health providers. For those of you who are among our valued customers and are listening today, please look forward to more information coming your way that's going to detail the specific DeVero response and plan.
Thanks, Kat. Now we're proud, as I mentioned, to have Healthcare Synergy's Michael Tidd on the line. Michael's an LVN who's been around for with 18 years of regulatory experience, and he's the go-to guy for Healthcare Synergy and has worked hard on putting this together for us. And at this time, I'd like to turn it over and introduce Michael.
Well, hello. Thank you, Robert. I appreciate that. As Robert said, a lot of the information, well, all the information presented is in the slides. So what you will see when you download the handouts are exactly what you're going to see on the slides. There are items that we're going to be covering because a lot of them aren't new. They simply rearranged the PowerPoint presentation. They've rearranged some of the items in the COPs. So you're not really going to miss out on anything. You will have the handouts. But the items in black font in the handouts as well as on the slides is existing information. It's just highlighted in the slides so you're aware of where it's now located at. The condition of participations are going to take effect July 13th of 2017. I've provided the link here if you want to download, and I would strongly encourage you to download the document itself, fully read it, because regardless of what I say, it's factual, trust me, but regardless of what I say, you can't talk to a surveyor and say, well, Michael Tidd said this on a webinar that he attended. You're going to be held accountable for the information that's in the conditions of participation. All of the information presented today, except for one specific section or standard in the quality assessment section, is going to take effect July 13th. That specific area that is not going to be effective until January 2018 is contained in the slides as well, but that is section D, 484.65D. So the condition of participation, there are many items that have changed, simply being rearranged in different sections. We're going to cover today a high-level overview, just as about 5 slides of the detailed information. Then we're going to dive deep into the pertinent information that has changed. As Robert said, some of the slides that haven't changed, we'll just skip by those. You're not missing any information. They are available in the handouts for you. So our high-level overview, the COP is broken down into 3 sections like the standard one. 44.1 to 44.2 is your general provisions. 484.40 to 484.80 is your patient care. That's delivering the quality care patient the service to the patients, the types of disciplines that can provide that and such. 484.100 to 484.115 is your organizational environment, the structure of your organization, your branches and such. This is a combination of all the standards that are in the 45, the conditions of participation. And there are 2 brand new standards that are listed here, the QAPI as well as infection control, that we'll be covering as well. There has been elimination of some key standards that you'll want to be aware of. The 60-day summary to the physician is no longer a requirement according to the conditions of participation. The group of professionals has been eliminated. The quarterly record review is no longer a requirement of conditions of participation. And a subunit, a type of organizational structure, is no longer present in the conditions of participation, and those will need to be converted to a branch by July 13th, 2017 if your organization has a subunit. There is another slide detailing that a little bit, but be aware there is a lead time for that process to take effect. So you can't wait until July 10th to be able to start that structure. You need to make sure it happens prior to that. I would suggest at the very early or very latest start that process by May so that you're on target for that. Now, I specifically said the quarterly review and the 60-day summary review are no longer part of the conditions of participation. If you are an accredited agency through JCO or another accrediting agency, that still may be required by that functionality by that accrediting agency. So don't take the fact that you no longer have to do 60-day summaries or your quarterly record review. If that is a requirement of your accrediting agency, that is still a requirement even though it's not part of the conditions of participation any longer. There are a few key changes that took place in the conditions of participation, reorganization, and structure. The primary one is that the governing body and the administrator now have a higher level of accountability. It is expected. As we get to the very end of the presentation, we'll talk about the administrator's responsibilities, but it is expected that the governing body and the administrator are accountable for all operations of all branches and locations, not just the primary. So as we get down to that point, you'll find that the administrator is supposed to be responsible and know what's occurring at each of the locations on a daily basis. There is a new clinical manager designation. We'll cover that. They've greatly expanded the patient rights, and this is probably the area that is going to take the most time in preparation on your part, and we'll cover the details on that. A focus of care coordination and care planning. This has always been part of the conditions of participation, the coordination of care between the different disciplines, the physicians that are working with the patient, but you'll see there's an increased focus and requirement for that. An expanded assessment process as well as plan of care requirements. And then a summary of the time frame required for transfer and discharge. That is a specific new area in regard to the patient's rights and the comprehensive assessment. And then supervision and training of your home health aides are the main key points that you'll need to take away from this presentation. There's 5 principles that are stated in the opening remarks of the conditions of participation. They are focusing on the patient's rights, increasing the quality of care, which you may have picked up through value-based purchasing and other models, the 5-star that you're seeing and may be affected by definitely 5-star, but the value-based purchasing depending on where you are attending from. There is definitely a focus on performance improvement. The conditions of participation, the focus, or one of the changes, is to remove the administrative focus on things that no longer work, that are projects that lack focus or evidence based on predicting the improvement of the patient or possibly preventing harmful outcomes. If those things aren't effective, they are now looking at changing those to what is effective for your agency. They are looking at improving the patient-centered. We've always heard that the plan of care needs to be patient-specific. There is an increased requirement for that. spelled out when we get to the plan of care section, and interdisciplinary coordination to make sure we're meeting the needs of the patient. We're focusing on building a continuous integrated care process utilizing all of the disciplines. One of the things that is fairly evident when you go through the conditions of participation is where this Medicare wants to move away from a single discipline such as the assessing RN, deciding what the care is needed for this patient, and working with clinicians that don't come into the office regularly, don't participate in a care coordination meeting. So that is one of the big focuses they're looking for, is how to coordinate with all of the clinicians that are working on a particular patient's case and make sure that all the clinicians are aware of what the interventions are, the goals are, and how to work together as a team. In case you came in late, Robert said there are handouts available, but we're also going to be doing questions and answers at the very, very end of this. So feel free to type in your questions in the GoToWebinar panel on the side. Now we're going to dive deep into the conditions of participation, starting with the details of the conditions of participation. There are some definitions you need to be aware of, some that are new, some that are revised, and some that have totally been eliminated. As I go through the slides, I'm not going to read each and everything listed here. They're kind of spoken for you or listed for you to review. But one of the items is verbal orders are a spoken order. I think we're all aware of that, but verbal orders are going to be key when we get down to coordination of care and plan of care. Branch office is defined as a parent agency providing supervision and administrative control of any branch. Branches are no longer a need to meet the COP independently. That is because they are structured to be overseen by the administrator, and I have already said the administrator is the one that needs to understand on a daily basis what's occurring with those branches and how to best meet those. They have eliminated bylaws, subunits, supervision, and home health agency as definitions in the conditions of participation. This is just a highlight of the sections we're going to be covering today as primary changed areas that you need to be aware of. In the patient's rights, this is the area that I'm probably going to speak for close to 12 to 15 minutes on, because it is a primary area that is going to require a significant amount of change. Each of the areas we're going to talk about are going to have a slide like this that lists the standards that are covered in those, and I've highlighted the specific areas of those standards that have changed so that you need to be aware of. But this is the area that's going to take the most significant amount of work. CMS is focused on making sure that we provide written and verbal notice to the patient or their caregiver, their representative. So we can't just simply hand them a piece of paper, have them sign it, and run out the door any longer. We need to make sure that we provide that to them as well as verbalize what its contents are. One of the changes that CMS has allowed is a summary of the rights in a conversational language and tone. So as you're going through that process, you don't have to read word for word everything that appears on your privacy statements, on their information statements and such. You can instead summarize that in a conversational tone, just as we're talking to the patient to see how their day is going and such, and make sure they're aware of those features and functionalities. They need to be able to have the contact information for the home health administrator because the focus is on the administrator as the one point of everything happening. You can provide the DCPS, the director of nursing, or another clinical manager's contact, but you must provide the home health agency's administrator's contact information as well. OASIS privacy notice is not new, but it's something that now needs to be provided. The information has to be provided within 4 business days of the initial evaluation visit. So it's not a requirement that you provide the privacy information and everything up front on that initial visit. Your RN, assuming that's a clinician going out to see the patient, is the one who can do the assessment, do the initial visit. Somebody else can then follow up within 4 days to provide that information to the patient, but they have to have it in writing within 4 days, whether it's hand-delivered or whether it is mailed to them. One of the big focuses is on a legally authorized person instead of a patient-selected individual. In some cases, our patients have a conservator assigned to them or a legally appointed caregiver that works for the patient, and that is the person that needs to be recognized and discussed all the matters with. You can discuss it with a patient-selected individual, but if there is a legal obligation or a legally selected or appointed person, that is the one that you have to speak to. So in red here, the change requires both written and verbal, as we talked about. There are timetables prescribed for that, and it has to be the legally authorized person. So this is going to be the area that's going to be revised the most. All of your current patient notices will need to be revised because they need to be in the language that the individual can understand and be able to read. Exercise of rights hasn't changed. We'll skip that. In the patient right bullet C, the rights of the patient, there are about 4 slides on this. The patient needs to be free of any verbal, mental, sexual, or physical abuse. Pretty straightforward, understandable. We would expect that with anybody. We need to include injuries of unknown source or neglect and misappropriation of property. So these are going to be areas that we're going to have to investigate if there is an injury and we can't discern what that came from. We need to be very aware for potential abuse of the patient, whether it's just a safety environment that somebody, the caregiver, is not cleaning appropriately or whatever. We need to be able to be aware of that. Any misappropriation or theft of property needs to be investigated as well. The ability for the patient to make complaints regarding the care has to actively be taken care of, and the expectation is that an agency will start an investigation for every single complaint. Most of you probably already do that, but it needs to be documented because now it's a condition of participation requirement. The surveyors will be looking for each of these bullet check items as they're going through. So the patient, the next section here is the patient has to be able to participate and encouraged to participate in each of these different bullet items. The completion of the comprehensive assessment. We've been told for years that this needs to be an observation and assessment of the patient, not an interview with the patient. But we now are required to encourage the patient to participate in that. Have the patient participate in cares furnished based on the comprehensive assessment, what services they want, again going back towards the patient-centered plan of care, establish and revising the plan of care to make sure it meets what the patient's goals are. The disciplines that furnish care, we're all familiar that patients may refuse therapy services, but they have the ability to acknowledge and accept the different disciplines. And the visit frequency, how frequently will visits be done? All of those areas, the patient needs to be encouraged to participate. Obviously, we can't force them to. One of the big new items is the expected outcome of care. What does the patient want? In addition, what is our clinical objective view of what is possible? We need to include the patient-identified goals and the anticipated risks and benefits of those items. Any of these factors could impact the treatment and the effectiveness. The new rule specifically prescribes terms of the detail of information that is provided, as well as the advanced directive information has been dropped from the COPs, but it still remains a requirement in 489.100. Those last 2 items are bulleted because we still need to wait and see what the surveyor interpretive guidelines will be, so we better understand how the surveyors are going to be instructed to look for these items in the care and the documentation we provide. In the patient's rights, the patient needs to receive all the services outlined in the plan of care. It's pretty obvious, but it is now listed as a requirement in the conditions of participation as we're going through, so they may need to receive all of those items. The rest of these items I'll let you leave. Those aren't a change to the plan of care. They're just emphasizing HIPAA privacy, changes to the care plan, be giving them advice of when the schedule is going to change and so on. The hotline is still a requirement. That hasn't changed, but they now need to list in your documentation you give to the patient these 5 key items: the agency contact information for the Agency on Aging, the Centers for Independent Living, the Protection and Advocacy Agency, the Aging and Disability Resource Center, and the QIO. So they need to have a contact name and a phone number and an address to be able to contact each of those individuals in the documentation that you give them, so they can, the patient, if they choose, can reach out to those individuals. They have to be free of any discrimination, but the patients have to be informed of the right to access auxiliary aids and language services and how to access these services. The language translation and other services would have to be, they'd have to be warned of those or advised on how to contact those. Transfer and discharge is a brand new area that they're focusing. Obviously all of you have transfer and discharge policies. You'll probably need to review those to make sure they're compliant with these. But CMS has now spelled out specific areas that are listed on this slide of when you can discharge a patient, what those items are. So the patient or representative, if any, have a right to be informed by the home health agency policies, admission, transfer, and discharge. The home health agency may only transfer or discharge the patient if, and these are the items from the COP, the acuity requires another level of care. Home health agencies must arrange a safe and appropriate transfer if the patient needs a service that they're no longer able to provide. If there is no payment, you can discharge the patient, but the state laws would have to be consulted. There are some states that do not allow an agency to discharge a patient simply because they cannot pay for services. The physician and the home health agency must agree with the goals, that the goals have been met. In the past, agencies were able to discharge when goals were met. That was in their plan of care. The focus now is involvement of the physician, so you must have a written chain of events to be able to document during a survey or an ADR or other service that the physician has been consulted, the physician acknowledges that the goals have been met as well. A patient refuses care or elects transfer or discharge, the agency can discharge. If the patient causes disruptive, abusive, or uncooperative behavior, agencies can discharge that patient. There are further bullets here that the patient, the agency has to advise the patient and the physician of the plan to discharge and transfer because of those disruptive, abusive, or uncooperative behavior. Efforts have to be made to resolve problems before transfer and discharge where appropriate. If the patient's being disruptive, abusive, uncooperative, you need to provide education to that patient, again in the language and the manner they're able to comprehend, that those items are no longer acceptable and they will be discharged if those items don't change, and make every effort to change those processes. Provide the patient with contact information of the agency that is being transferred if you're transferring a patient. So you can't simply discharge a patient and assume another agency is going to pick them up. You physically have to tell the patient the agency you're transferring them to, so they're aware of that, and then for documentation purposes, document every single effort that was made to resolve the issue prior to the discharge process. Obviously, death of a patient is result for discharge, or if a home health agency ceases to operate. One of the things that is very important that's spelled out in the conditions participation is an agency can no longer discharge a patient simply because they don't have adequate staff. This was really stressed in the NOC presentation as well, that if an agency takes a patient on and they have staff that quit, so beyond their control, but CMS does not expect an agency to discharge or transfer a patient because of staffing problems. The agency still has the need, specifically from CMS, to provide coverage for that patient. Now they can obviously arrange transfer to another agency, but be aware that CMS is going to be looking at those specific items because they were specifically asked that question by NAC, and the information was, no, you can't transfer just because you had some people quit. They suspect adequate coverage. So CMS pulled out, see, these are kind of summaries of the CMS view, that physical and electronic records outlining acceptable reasons of the transfer must exist. CMS is looking at the discharge for safety of the individuals, but they have to have cause. So you have to look at the cause reasons. What is a cause standard that is being applied? Simply stated, CMS says do not include inadequate clinical resources. This is the reference that I made about not having enough staff as cause for a reason for discharge. Home health agency needs to review the state licensing laws and of the discharge and apply the standard that most protects the patient. And additionally, a review of the agency policies should be looked at to see which is more restrictive in the analyzing conditions of participation. The focus on investigation is a significant concern of CMS. You must document all the different steps that your agency has done in the process of an investigation for the treatment of care, mistreatment or neglect of the patient, any verbal, mental, or physical abuse, including the injuries of unknown source, misappropriation of patient's property by anyone furnishing care on behalf of the home health agency, and then the home health agency is responsible for asking the necessary questions to determine the cause of the injuries. So CMS is demonstrating in this that they have a concern not enough effort is being taken by agencies to make sure that the patients are safe and that we're following through with their complaints. They're just being shrugged off and neglected. So you must document each and every one of those steps that you've taken and the resulting outcome so that when a review, a survey is done, you'll be able to have that. The documentation of the complication, the complaint, and its resolution as stated. Take action to prevent further violations, including retaliation while the complaint is being processed. Staff members must immediately report to the home health agency the other appropriate authorities if they've identified theft, or if they notice or recognize incidents that occur, circumstances of mistreatment or neglect, verbal, mental, sexual abuse, and so on, and then report consistent based on your state law. Accessibility of the patient is a new area for a focus on this particular item. Information must be provided to patient in their plain language and in a manner that is accessible and timely to them. We talked about the four business day process. Has to be in their language they can review and understand, but specifically pointed out in the COPs is that your website has to be in a language they can understand. The auxiliary aids must be provided at no cost, compliant with the ADA Act, American Disability Act, if you're not familiar with that. The limited English proficiency language services at no cost, including oral and written transmissions to the documentation, must be provided. So the focus is not just to be able to throw something at them and say it's been delivered, sign here, but that they physically understand and are able to see and understand that information. New as a condition participation, but essentially already present under the LEP laws, provides some flexibility under when an undue burden is experienced, is defined in Section 504 of the Rehabilitation Act. So while this is needed, it's not necessarily new to a lot of agencies. Comprehensive assessment hasn't essentially changed. I've highlighted two areas here. The contents of the comprehensive has changed somewhat, but most of you are probably already meeting that requirement. We'll talk about what those are, and then update of the comprehensive assessment itself. So we're going to skip by these first couple slides because nothing's changed there. You still have to do the OASIS assessment, and RN goes out and so on. The change here is that in the past, CMS has simply stated you needed to have a comprehensive assessment developed by the agency in addition to the OASIS questions. CMS is now stating that you must have current health, psychosocial, functional, and cognitive status questions in your assessment. In this particular process, this is the paragraph specifically from page 4531 of the conditions participation, where they're stating that they need those. If you jump down to the middle of this paragraph with the series of ellipses there, we are not requiring the use of any particular tool, nor are we prescribing the extent of the cognitive status assessment. Our goal is to make cognitive assessment a routine practice in home health so that home health can use this information in developing and implementing the patient-specific plan of care, and so that home health agencies identify potentially unmet patient needs that warrant follow-up care from another healthcare provider. So while they're asking for these specific items or areas, their current health, their psychosocial, functional, and cognitive status, they're not dictating exactly what your questions must be. If you're using DeVero, for example, you're using Synergy, these functionalities are already there. More than likely, these specific questions and functionalities are present in your other software package you may be using. Just be sure that you review to make sure that those specific areas are present and possibly ask for changes if needed and so on. The patient's strengths and goals and care preferences are a focus of the assessment now. What is the patient's strengths? What are they able to do with their current disability or situation that they're in? What are the goals of the patient and their care preferences? That's stressed in developing the care plan and developing the assessment. The focus is on the information that may be used to demonstrate the patient's progress towards achieving of goals. Home health agencies are usually good about documenting the care provided, but now CMS is looking for them to demonstrate the progress that the patient has made towards meeting goals. They may not have achieved a goal yet, but what progress are they at towards achieving that goal? And the patient has to have measurable outcomes that identify the achievement of those goals. So that's the big focus of the conditions participation, is better quality, and how do you measure that? The statement from CMS on page 4531 goes on to say, traditionally the home health care plan has been developed with a focus on patient deficits that require treatment. This model of care places patients in a passive recipient role that does not optimize the achievement of positive patient outcomes. First, this model does not take into account those patient strengths that can be harnessed by the staff and plan of care to facilitate patient well-being. Each patient has their own set of care preferences, and we would require home health agencies to both identify and respect these care preferences to the greatest degree possible. Our goal is to assure that home health agency plans for and provides care that is both patient-directed and in accordance with the physician-ordered plan of care. These are items still remain as part of the process of non-compliance with drug therapy, duplicate drug therapy interactions, and so on need to be reviewed. The continuation of the contents of assessments is that you need to have in the assessment these specific items. The primary caregivers, which is probably already in your assessment, if any, and the available supports that the patient may have. What is the patient or the caregiver's willingness and ability to provide care is probably already there, but it needs to be if it's not. The availability and schedules is something that's probably not in most of your documentation that now needs to be there. And the patient's representatives must be identified so that as you're going through, these need to be reviewed and make sure they're part of your comprehensive assessment, if not already. One area that has changed in update of the assessment is what's highlighted in red. In the past, when a patient was going to be discharged from a hospital, you had 48 hours to be able to provide the care to that patient from when you became aware of the discharge or when the discharge occurred. In some cases, you're not able to resume that resumption of care immediately within that 48-hour period because a physician ordered a different date. Now in the conditions of participation, if you have a physician-ordered resumption of care date, that is now your requirement, and you are now covered if that care does not happen within 48 hours of you becoming aware of the resumption of care date or of 48 hours of when the discharge occurred. So that's a very important item. It's going to give a lot of agencies a lot more leeway in doing their process and now be found compliant. Care planning is another major section that needs to be covered and be aware of. We're touching pretty much every section in the care planning has something that has changed. The focus of the care plan is that it's individualized care plan that meets the specific care and services necessary for a patient-specific need. That's not really new, as we stated earlier, but we need to identify in the comprehensive assessment and include identification of the responsible disciplines that will carry that out and the measurable outcomes of the home health agency that anticipates anticipation of what will occur as a result of implementing and coordinating the care plan. The individual plan of care must be specific to the patient and specify the caregiver's education and training that the home health aide will provide, specific to the patient's care needs. So we're going to touch on 4 of these. We're going to skip the discharge or transfer summary section. The patient-specific measurable outcomes and goals have to be listed. Emphasis on the measurable outcomes. need to be provided in the care plan itself. In Section 2 of Plan of Care, the two brand new items that are not previously present is a description of the patient's risk of emergency department visits and hospitalizations, readmission, and all necessary interventions to address the underlying risk factors need to be present in the care plan. What is your anticipation? Obviously, our focus in providing care and a focus of CMS is to minimize or reduce the number of rehospitalizations that occur. Now they're looking to specifically document in the client care plan what those risks are and how you can overcome those risks, as opposed to reacting when one of them occurs. So it's going to take a little bit more forethought in that process to make sure that happens. In the black text right below that, their goal obviously is to reduce the number of hospitalizations, but they've also removed the risk scale, high, low, medium, that is present in a lot of your functionality. The patient and caregiver education and training needs to be facilitated in a timely discharge. So this focuses on discharge planning. How are we making sure that happens? What kind of training and education is being provided to do that timely discharge for the patient? Patient-specific interventions and education, measurable outcomes and goals, specifically stated again of what their focus is. This is the specific XIV bullet or substandard of 2 that dictates of those measurable goals and that need to be prescribed. And then information related to any and all advanced directives. We've had advanced directives for a very long time. Now it's actually part of the conditions of participation for you to be aware of. It should be noted, the very last bullet on this slide, advanced directives need to be moved to a Medicare provider agreement in 489.100. So they've been removed from the conditions of participation, but they're still a requirement or need to be aware of. The red bullet here is that the physician's orders must be documented as far as the patient's clinical record and signed and dated by the time. So verbal orders, it's probably a practice, but if not, it needs to be dated as to the time as well. It's big focus of CMS now as you read through the care plan that they want to know what the time is on each and every verbal order, because some patients' conditions decline so rapidly that the timing of those orders are very specific and beneficial in understanding that process. When you're reading the final rule as well, the final rule now allows verbal orders to be obtained by any legal entity, clinical entity in your organization based on your state laws. They don't go so far as in the conditions of participation as saying now LVNs can do that, but if your state allows in the scope of practice for an LVN, LPN to be able to capture verbal orders, the condition of participations now allow that. Bullet 3 there specifically says accepted only by personnel authorized to do so by applicable state laws. So that gives a lot of flexibility for the agency staff to be able to go through. Under review and revision of the care plan, these are two important areas that you're going to need to revise, and it will be a significant change to how agencies currently operate, as well as how your software works. Any revision to the care plan due to a change in a patient's health status must be communicated to the patient, the representative, if any, the caregiver, and the physician who's responsible for home health aid care plan. So that's most likely already being done. Any revisions related to the plan of the patient's discharge must be communicated to the patient, the representative, the caregiver, all physicians issuing orders on the home health care plan, and the patient's primary care practitioner or other healthcare professionals who will be responsible providing care and services to the patient after discharge. So this is a step that may already be doing. The emphasis is on all physicians that are issuing orders for the patient. Another area is that all orders must now be in the plan of care. A lot of agencies have had the practice to where they do a verbal order, they send it out, they start following that. What CMS is finding is a lot of those verbal orders are getting misplaced, mislost, and it's hard to track those. They now want every single order to be in the 45. The 45 should be a living document. It's going to take a lot of edit and changes on the part of the agency to be able to make that happen. Page 4535, commenter requested whether to clarify the change and whether it requires the plan of care to be re-signed by the physician, and if not, explicitly when that would and would not be required. The response CMS gave is the signature of the physician who is responsible for issuing orders related to the conditions that led to the initiation of home health services should be on all iterations of the individualized plan of care for each patient in accordance with the requirements. One of the things that's not immediately obvious by this, but analyzed and pointed out by NOC when they did their presentation, is that any of the verbal orders need to be done. They want to, CMS wants to reduce or eliminate multiple physicians providing orders that the primary certified physician that signs the plan of care and monitors is aware of in that process. So the one physician that certifies, signs the plan of care, tracks that, it needs to be aware of all the plan of cares, all of the orders, and that's what putting on all orders on the 45 is going to happen. And ensures communications with all involved with all physicians. Integrate orders from all physicians need to be on the plan of care. I stated that on the previous slide in anticipation of this, I'm sorry. I underlined and bolded that all orders from all physicians must be included on the plan of care, and the plan of care must be reviewed and signed by the physician responsible for the home health aid plan of care. There is no specification whether that has to happen each and every time there's an order, whether that can be done in a week. We need to wait and see what the interpretive guidelines are going to say on that process, but that can be a significant overhead for the agency as well as the staff. So we need to integrate those services, make sure that they're provided correctly, coordinate care delivery to meet the patient's needs in that process, and ensure that each patient and his or her caregivers, where applicable, receive the ongoing training and education provided by the agency appropriate and regarding the care and services identified in the care plan. Patient information written hasn't changed. The QAPI is brand new. The focus of this is the patient home health agency must develop and implement, evaluate, and maintain an effective ongoing home health wide driven, quality-driven process. A lot of the QAPI practices have been in place by several agencies. CMS is just defining what those are. And again, all of these except for item D are active July 13th, 2017. So the program scope, the agency must be at least capable of showing measurable improvement in indicators of which there is evidence that improvement in those indicators will improve the health outcomes of the patient. The agency must measure and analyze and track quality indicators of those practices. So those need to be happening on July 13th, if not sooner. The program must utilize program quality indicators where applicable. Home health agency must use the data collected, monitor the effectiveness and the safety and quality of the patient, identify opportunities for improvement. And the frequency and detail of the collection must be approved by the governing body. So you set the frequency of those processes yourself, but they need to be implemented in that process. This is item C of the QAPI items. Home health agency performs an improvement activities, focus of high risk, high volume, problem-prone areas. Consider incidences, prevalence, as well as severity of the problems in those areas, and that lead to an immediate correction of any identified problem that directly or potentially threatens the health or the safety of the patient. Performance improvement activities must track adverse patient effects and analyze their cause and implement preventive actions in the future. And after implementing these actions, the agency must measure its success and track performance to ensure the improvements are sustained. Those are all part of A, B, and C. Those have to be done by or before January 13th. I'm sorry, I read this slide, before July 13th. This, item D, is the only one that is delayed effect until January 2018. So the number and scope of the distinct improvement projects conducted annually must reflect the scope and the complexity of the operations performed. Agency must develop the quality improvement projects undertaken, the reason, the condition, and the conducting of those projects, and the measurable progress achieved in those projects. Page 4540, we have added a phase in to allow home health agencies time necessary to collect data prior to implementing performance improvement projects. This will allow for a full 12-month period beginning between the time that this final rule is published and the time that home health agencies must conduct performance evaluation processes. So that step has to start now, even though the conditions of participation are effective July 13th. The governing body is responsible for ensuring the following: that an ongoing program for quality improvement and patient safety is defined, that the home health agency-wide quality measurement and assessment performance improvement efforts address the parties for improved quality, and that all improvement actions are evaluated for effectiveness, and that patient safety is established, implemented, and maintained, and that any findings of fraud or waste are appropriately addressed. Infection control is something that you're probably already doing, especially if you're accredited. These are the items that are listed: the prevention of the patient practice, including use of standard precautions to prevent transmission of infection and communicable diseases, which is a standard practice already. Control maintained by core agency coordinated program, surveillance, prevention, identification, and so on. A method of identifying infectious and communicable disease problems, and a plan of the appropriate actions that are expected to result in improvement and disease prevention. And education must be provided for the entire staff, the patients, and caregivers. Again, that's not new if you're an accredited agency. Skills professionals, the only thing that's really new under this item is that they've combined, for simplicity, 484.30, 484.32, and 484.34. So your skilled nursing services, your therapy services, OT, PT, speech, and social work, medical social workers have all been combined in this process. Due to time, we're not going to review these. These are specific steps they're looking for them to be done, and supervision still needs to be provided by a qualified individual. Home health agency, home health aid staff have changed somewhat. Their home health aid qualifications are listed, and we're going to go through these specific bullets. A nurse aid training and competency evaluation program approved by the state as meeting the requirements set out by 483.151 through 483.154 of this chapter, and is currently listed in good standing by the agency. So you need to be able to not only provide the training, but the competency evaluation is one of the key new areas that needs to be developed. How do you demonstrate that is further documented that in item 2 that an agency has to be able to focus on the completed program and be able to go for that. It is important that this is going to be for all new hires going forward, as well as existing staff who need to be able to do this. In section B of the home health aid services, the communication skills, including the ability to read, write, and verbally report clinical information to the patient, representatives, and the caregivers, as well as other home health agency staff, must be addressed in the training program. Be clear on how they communicate. In section B still, they've added a new bullet item that the recognizing and reporting changes in skin condition. This is something your home health aides are probably already being trained for, but you now need to make sure that's there, document that that training has occurred, and the instruction and how it was received. Oddly enough, it does not cover pressure ulcers. It's defined as being out of their typical scope of practice, so your nurses will still be responsible for that, specifically for the deterioration of pressure ulcers themselves. Home health aide is responsible for training home health aides as needed for skilled, not covered, or for skills not covered in the basic checklist as described in paragraph 3B3 IX, which is listed in this listing that we have here. Kind of odd that they put that, but this is exactly how it comes. The bold statement there at the very back, the very end in black, current and new hires must be trained on the new requirements by 7/13. And the Home Health Agency must maintain documentation that demonstrates that the requirements of this standard have been met. This references only back to B3I, so when we go back to this particular section, I in the red here, 3I is what they're referencing. So that's not necessarily new. We won't read that again. Skipping down through these others, all of these have been maintained except again in red. So in F, eligibility training and competency evaluation organizations, we need now for home health aid purposes that have been excluded from participating in federal health care programs or debarred from participating in any government project. This is defining specifically who can provide training and competency evaluation, not the home health aid themselves, but anybody that, if you check the IG list or the LEI list of individuals that are no longer allowed to practice medicine, they can't be trainers either. Seems common sense, but it's specifically listed there. Home health aides are assigned to specific patients by a registered nurse or by appropriate skilled professionals. This now opens it up to having the OT, the PT, the speech therapist, as well as the RN to be able to assign, overview, review, supervise your home health aides. It has to have a written patient care plan, instructions by any of those disciplines, and must be prepared for home health. So it's now appropriate for any skilled professional to be able to provide the care and oversight of those individuals. Greatly aids and releases some of the responsibility for some of your other staff. The home health aides underneath assignment and duties must be members of the interdisciplinary team. So again, we don't want the clinicians going out, running about, providing care, not reporting back to anybody. The CMS's focus is that you have an interdisciplinary team that meets and coordinates care of the patient. Home health aides must be part of that team. They must report changes to the patient's condition to the registered nurse or the appropriate skilled professional, PT, OT, or speech, and they must complete appropriate records in compliance with the home health aides policies and procedures. Any home health aid services are provided to a patient who is receiving skilled nursing, PT, OT, speech services. A registered nurse or another skilled discipline that is familiar with the patient and provides written patient care instructions as described in 484.80G. And then a registered nurse or another skilled professional, PT, OT, SP again, must make an annual on-site visit to the location where a patient is receiving care in order to observe and assess each aide while he or she is performing that care. Skipping forward to one of the last two sections of this home health aid services is that a home health aid supervision must ensure that aid furnished care in a safe and effective manner, including but not limited to the following elements. So now you've already done that supervision, but they physically have to be able to see them, follow the plan of care, maintaining an open communication process, demonstrating competency with assigned tasks. Page 45, 47, all elements set forth in paragraph H4, which is what's on the screen, need to be accounted for in each and every supervisory visit. It's not highlighted in red, but I wanted to read it to make sure you're aware of that. So in each and every supervisory visit, they have to be able to make sure that all of those are being accomplished. That kind of closes out all of the new items in home health aid. Coming to the very closing section of the organizational environment. These are the specific sections that have changed in red, and we're going to highlight just a few slides covering those items. One of the big changes here is that it incorporates 484.14 item J on laboratory services. Home health and its staff must operate and furnish services in compliance with all applicable federal state laws. Disclosure of ownership and management information. Home health aid must comply with, the agency must comply with requirements of the subpart B, name and address of all persons' ownership, and so on. The home health agency may not substitute home health equipment for a patient's equipment when assisting with self-administration. This is a very important item to be aware of because a lot of your clinicians, home health aides, will go around with their own glucose meters. Some of your nurses may go with their own portable PT-INR check. You're no longer allowed to provide those instances. You must use the patient you must use the patient provided equipment when it's present. The paragraph at the bottom here on page 4547 outlines the case where an agency may use their own equipment. I've underlined the specific statement. Agencies may use their own self-administered testing equipment for a short, defined period of time when the patient has not yet obtained his or her testing equipment, such as in the days immediately following a physician's order to obtain the testing equipment and when a patient may not have the time or the resources immediately available to complete the process. So a patient needs to have their own equipment to be able to do the different tests and administration, blood pressure checks and such. The agency cannot use their own unless the case where the patient doesn't have those, and they should be able to make sure they have those, or at least have them ordered. Underneath the organization section 105, administration and clinical manager are two small changes. The governing body must assume full legal authority and responsibility of the agency's overall management and operation. As we said in the very start of this process, that means the administrator has to be aware of what happens in all of the different agencies. Administrator must be appointed to report to the governing body. So the administrator is the one buck stops here type of person. They're responsible for everything that happens. They have to be responsible for all daily operations of the home health agency. That includes all of the branches that may be present. Another section in section 3 here, the administrator of a pre-designated person is available during all operating hours. It doesn't go so far as to specify that they have to be present at the agency for all hours during operational hours, but they need to be available to be contacted. And you saw that in the very first, in the patient's rights, that the administrator has to have their phone number, their contact information must be provided. It's not just a matter of call the agency and ask for the administrator. The CMS's real goal is to eliminate where multiple agencies are sharing administrators. The focus is that a single administrator has such overwhelming obligations that they need to be at that one agency and be answerable to all of those areas. A clinical manager is a new role. It basically replaces your supervising nurse, as noted at the very bottom. Page 4550 is where it outlines the clinical manager, so you can read more in depth on that. But it's one or more qualified individual who must provide oversight of all patient care services. Oversight must include the following: making patient and personal assignments, coordinating patient care, coordinating referrals, assuring that the patient needs are continually assessed, and assuring the development, implementation, and updates of the individualized care plan. So the bullet point takeaways is that you can have multiple clinical managers. They can be any of your qualified staff. Read that as your OASIS assessing staff. A PT, an OT, a speech therapist, or an RN can be a clinical manager in that process. Read that bullet point 4550 to be able to read more about those and be able to better protect yourself. The parent-branch relationship, there's not a lot new there except that the agency is now expecting that the administrative control is directly supported and overseen by the home health agency itself. Branches don't run by themselves effectively. This is the subunit part. I think we've got about 3 more slides. I apologize about going over. I'm rattling through as quickly as I can, but hopefully it's making sense to you. Subunit designation is going to be eliminated by 7/13/2017. Page 4551 states that subunits are already the equivalent of a standalone home health agency and will be able to continue functioning as such, relieving the need to change to branches. So you can elevate a subunit to an existing standalone agency if you need to, or you can convert those into branches if needed. The statement that I have at the very, very bottom here, agencies and states with a moratorium may have problems as branches are not being approved. It may need to become a parent. If not a branch or a parent by 7/13, then any services you do, the claims out of that subunit will be denied. The action needs to start now, or at least by May, and my recommendation is that you have to do the 855 work and they get a new provider number and so on, and that change takes time. So start that already if you're not. The clinical record itself has content changes, authentication, and retention of records. Quite a few on the content of the clinical record, the contact information of the patient and patient's representatives. That should be part of your comprehensive assessment now. The contact information for primary caregiver, practitioner, or other healthcare professionals who will be responsible for providing care and services to the patient after discharge. Again, an item that should now be part of the comprehensive assessment. A completed discharge summary that is sent to the primary care practitioner or other healthcare who will be responsible for providing care now has a specific time period of 5 business days after the patient's discharge. So that 5-day period is specific or pertinent. A completed transfer summary that is sent within 2 business days of a planned transfer, and the patient's care will be immediately continued into another healthcare facility. Completed transfer summary that is sent within 2 business days of becoming aware of an unplanned transfer if the patient is still receiving care from a healthcare facility at the time the healthcare home health agency becomes aware of the transfer. The contents of these items aren't specified. That's actually deferred to the Impact Act, but be aware those are new requirements that you'll need to review for 84.110 Section A to be able to be aware of. Going back to the time and the date, it's very important to have the date and the time and the signature and a title of the individual getting those items. They clarify that time means the actual time that an event occurred, not the time that you made the order, the time that it was recorded. I've underlined that and point you back to page 4550 for that additional information. Again, here at the very bottom, interpretive guidelines will need to be consulted to see if every procedure needs to be dated and timed, or whether the date and time of the visit note are sufficient. So when there are multiple procedures done in a single visit, NAC's interpretation is that each and every procedure that's done needs to be signed, dated, and timed. That's going to be a big administrative overhead if that is really what the interpretive guidelines point needs to be done, instead of simply being able to list in a narrative statement all of the procedures done and then sign the visit note. So that needs some further guidance, watching for those interpretive guidelines to be able to tell. The retention of records has one change. It's 5 years after the discharge of the patient, unless the state law stipulates something different. That is a change to the time point, referencing, again, the discharge of the patient is now that particular item. If a home health agency ceases to operate, you still have to be able to show records and inform the state agency where those records are maintained. Protection of records hasn't changed. 2 last slides, I think, in personal qualifications. The administrator of the home health agency is the individual that, an important thing to know about this is any of your existing administrators are grandfathered in. These bullet points in 1, 2 here are for new administrators that begin employment on or after July 13th. So if you hire a previous administrator, they're going to still require these requirements. If you have an existing administrator that's staying on, they don't need, but it needs to be either a licensed physician or is a registered nurse or has training and experience in home health service administration of at least 1 year of supervisory administrative experience that's related to the healthcare program. They also need to be individuals that begin again on after July 13th. They need to be a licensed physician, nurse, or holds undergraduate degree is one of the new requirements for that particular process. So if they don't have an undergraduate degree, which most of your nurses, your physicians obviously do, your therapists and such, but they need to have an undergraduate degree, otherwise they cannot be an administrator. Again, this is for new hires on or after July 13th. grandfather clause to current administrators. A clinical manager is a person that is a licensed physician, physical therapist, speech-language pathologist or speech therapist, an occupational therapist, audiologist, social worker, or a registered nurse. So now that you have the clinical manager, this is the statement that allows you to use any of those differences. A social worker, it has to have a doctorate degree now in going forward, and a speech-language pathologist has a master's or a doctorate degree. So they've added both of those as qualifying factors. So I apologize for going 12 minutes over. You do have all of that information to read, go over, to be able to digest. All of those slides we skipped or might have went too fast for you are available in the handouts. I encourage you to download those if you haven't. The email addresses for myself, Kat Zinsman, or Robert Love are listed here as well if you want additional information. Watch the replay that Robert will be sending out to all the registered attendees. And if we have any questions, we can accept those now, Robert.
Yeah, I think what I'll do, if you don't mind, I'm going to go ahead and display my my screen, and
feel free, go ahead.
And then that way you can open up your question pane and check out the questions that you might want to answer. There's a number of questions, and what I think we will do is you can answer any of them as you're able to. If folks want to hang on the line, if not, we'll get to some of them via email. And again, I'm going to end the recording here. This will be recorded and sent out to the folks who registered, and we thank you for attending.